Hello, everyone, and welcome to Fostering New Use Cases for Virtual Care. My name is Wendy Potma-Brain, and I am the Manager of Clinical Implementation Services at AvaSure. And I am so thrilled to have two people here from Maine Health. I've had the great opportunity of working with them since I think February of 2019. And I literally have been trying to get them come and present and be part of the symposium or webinar because I know they have such an amazing program, and I'm so excited that they get to. So let's go ahead and get started. Hannah and Val, tell us a little bit about your role and maybe a little bit about your telesitter program. And so Val, you want to start?
Sure. So my name is Valerie White, and I am the director of at Maine Medical Center of the Float Pool, the Float Companion Department, and Central Staffing. And all of that kind of intertwines. It's like a family, and the telesitter program falls under that umbrella. And so day to day, Hannah and I work together to make sure all of our companion requests and telesitter requests are met, among other things.
And Hannah.
And I'm Hannah Plummer. I'm the companion program supervisor here at Maine Medical Center in Portland, Maine. I am under Val, helping her do everything companion, including all telesitter things. We work in tandem to make sure that the program's running perfectly. And for our telesitter program, we have 24 ceiling mounted units in our emergency department. And just in the last year, we brought in, we had 3 mobile units, but we've expanded to 11 mobile units being used all throughout our inpatient units.
Yes, that's right. We call it phase 3. So phase 1, 2, and 3, you kind of keep on going as you see the need. Yeah. So what I really loved about your program is that the traditional path for most of our customers is to start their telesitter program with the acute care side of the hospital. But you all chose to start specifically and only in the ED. And again, with 24 ceiling devices. Why did you start in the ED? And then tell us a little bit about the process for determining to start in this area.
So we decided to start in the emergency department. Well, number one, we had a lot of companion requests in the inpatient departments, and we had already been talking about, looking at different companies that did that provided cameras for telesitting, and we had visited some other hospitals and made some phone calls to talk about that, using telesitters. But we chose the emergency department because we were already struggling, and then all of a sudden the regulatory requirements changed and were being heavily enforced. Prior to that change, we had been using security officers, or sometimes I think emergency department staff, to watch groups of patients in the emergency department. So they would be watching maybe 6 people in a corner, or 5 people that were in like rooms that were visible all together. And but that doesn't really qualify under the regulatory requirements for continuous observation for each person, because you can't see them at a good angle. So that is really the reason. And aside from that, the regulatory requirement was for suicidal patients that were at risk for suicide. And the emergency department has a higher number of those types of patients, because people will come into the emergency department, be evaluated, and then in order to have the risk of suicide order removed, they need to be evaluated by a provider. So there were a greater number in the emergency department than in inpatient units. So we chose to start our monitoring of people via telesitter there, and it's been successful.
When you say that you were doing like the 1 to 6, was that specifically behavioral health patients too prior to the changes?
Yes, because we had never provided the float pool and float companion department had never provided staff to the emergency department for that reason prior to the regulatory change. And it just happened very suddenly, and it was very overwhelming to try to provide a person per patient that needed, continuous observation for suicide risk. And so we had to come up with a different solution.
Yeah, because that's a lot of companions to send
Yes.
to the ED.
There were times that they had 21 patients that had not yet been cleared by providers.
Just in the emergency department.
Just in the emergency department. That's a really high number, but that was something that occurred.
Mm-hmm. So now I can see really why you wanted to start in the ED.
Yes.
And you said it sounds like you talked to different vendors. What made you decide to go with AvaSure?
Well, we visited Brigham and Women's Hospital in Boston we were actually visiting their central staffing office just to kind of see how they ran it and did things, looking for some positive change. And we actually got to visit the little room that they, made the magic happen. It seemed to work really well. And the telesitter that we talked to she seemed to love it, it seemed safe, and I could see where a telesitter could potentially feel even safer than having a person in there, because somebody's not going to fall asleep in a dark room by themselves, or something like that. So that's why.
Oh, that's great. And then as part of your program, again, in the ED, you have an area called APU, acute psych unit. So you also add devices in that acute psych unit, which is a locked unit, correct? Okay. So what are the difference between monitoring in the AP unit versus in the ED, which I know is part of the ED, but it is kind of separated?
Well, it definitely is separate. We showed it to you when you were visiting. But it definitely is a different type of unit. It is a 6-bed locked unit, as you said, where we created an environment that's ligature resistant. So when we were implementing the cameras, we had to ensure that they indeed could as well be ligature resistant. And so they had to be placed in certain places. And it definitely is a change to watch someone in the APU than the rest of the emergency department. If someone walks out of their room for a minute, you don't have to be as rushed to call for, if they're in elopement risk, because they're in a locked, safe unit. We also have a few rooms in that area with a closed circuit camera that's separate from our telesitter program, which allows us to watch high-risk suicide patients. So we have a one-to-one watching on this camera, ensuring that the staff is safe watching them if they're high risk for, also perhaps staff harm. And then we have telesitter that can be a second set of eyes for when, anything happened, if anything was to happen. So I think it definitely has been an improvement to that area, allowing people to know what's going on in the rooms, and the nurses feel more comfortable.
That's exactly what I was going to ask, because again, they have that backup, right? The nurses do. They definitely have somebody else keeping an eye on them, and they know that. Have they mentioned anything to you about that? Feeling safer?
Yeah, there's definitely time to time when you're down rounding on the unit, and they were saying that it's nice to know that there's someone watching and paying attention when they're in the room, so that they can be kept safe as well. I don't know that our staff worries frequently about being kept safe from their patients, but in an instance where someone might be a little more riled up, they know that there's someone paying attention, that if something was to happen, that they can alert to get help.
Oh, yeah, absolutely. So those high-risk patients then still, if they're in the APU, they'll be in the APU. They have a companion.
Yeah.
And so since the telesitters, do you find you're implementing the telesitter program? Are you really only sending sitters then to the APU unit for the most part?
So when there's an APU companion need, normally the emergency department will cover that because their techs are trained in that area.
Okay.
But we can watch our closed circuit camera, and that can be the one-to-one so
Yeah.
that they don't actually have to be in the room, because for safety, they
Mm-hmm.
can't be in with the patient. So it's a they're
Mm-hmm.
rooms that are completely safe for the patient, and they're being monitored one-to-one, and they have the backup of telesitter.
It sounds like you really have it set up pretty good there for the EPU units. I mean, I saw it, so yes, you do have it set up really good. Letting everybody else know I've seen it. It is great. It really is. So tell us a little bit about some of the successes you've had monitoring in the emergency department, and then how might have those successes contributed to the growth that has happened?
So we have had a significant number of, I guess you just call them near misses, some fall prevention or patients grabbing something that's unsafe, that have been discussed. Sometimes an RL will be put in, but really which is a risk reporting.
Okay.
And it turns out that the telesitter prevented something from happening. So there have been, multiple stories like that. And then in addition to that, the falls with injury has improved. Well, I think it has helped with decreasing falls in the emergency department, but also the statistics really that we have so far show that falls with injury have decreased, because somebody can intervene faster. And then I think that the cost savings is huge, and the ability to provide, to watch more patients, because you can only watch what you can watch. So we would have to have a one-to-one person with somebody that's suicidal, but there would be other people just left, not watched, because there just wasn't that option. So I think all of those reasons combined have led to wanting to expand.
You must have shared those successes then. Leadership throughout your hospital. They must have part of.
Yeah, so some of the leaders in the hospital, for instance, our director of quality at Maine Medical Center, and our vice president, Joy Moody, was involved with implementing the program at the beginning, and then emergency department leadership as well. But we have a program that we do every day here. It's called Operational Excellence. And we do Gemba walks. I don't know if you've heard of this.
Yes, I got to do them.
Okay, yeah. So in those environments, data is shared and stories are shared, like anecdotal and actual statistics are shared. And then obviously senior leaders share things with other senior leaders. So.
Oh, yeah, that's how the good word got.
Yes.
That's excellent. And I know that, didn't you do a little magnet story on the falls?
Oh, yes, we did. We did do a magnet story on the falls. Well, Hannah and I typed it up, and it was reviewed by our quality and research team. And that's where the statistics showed, when we compared the time frame, pre-telesitter, post-telesitter, that there was a decrease with falls with injury.
Yay. And I don't know, was that even part of what your plan was when you initially put those in, right? It was
no, we kind of, we knew that it would have some sort of impact, but that wasn't really, it was really more for the suicidal coverage, patient coverage.
Fantastic.
And it had that bonus to it.
Yeah, absolutely. So this is my favorite part, because I actually was there when we met with the neuro unit. So you chose to expand your program to monitoring epileptic patients in your EMU, which is in the inpatients. So what led to the decision for monitoring those types of patients?
So every week, well, pre-COVID, every week, and then now it's sort of off and on, but we would normally get 2 patients in per week for epilepsy monitoring. One requires a hospital provided companion, and one requires that they have to have a family member come in with them and promise that they're going to watch them while they're being monitored by EEG. And so we met with the neuro team. It actually is what brought Telesitter to the inpatient units, because the unit that does that monitoring was like, we need something, because the flow pool just can't always guarantee to give a companion every shift. So right now it's mostly a trial, we're just trialing at the moment. We are working very closely with the neurology team. They're hand selecting the patients that they find to be the most appropriate, that have kind of the most obvious seizure events that kind of are really easy to spot. And it is mostly to cover night shift for the patients who come in with their family. So that way the family can still sleep. And if we are seeing some sort of event, we can set off an alarm and they wake up and can hit the button to record the event. That's kind of the whole point of the EMU admission, is to record the event happening. So one thing that we did when we're implementing this is we made a special script for our telesitters when they're calling to get report on those types of patients, to make sure that they are like finding out, does the patient have an aura? What specific things are we looking for? Or is it a small tic that the patient does? Is it going to be a large seizure? Like very specific questions, so that we know exactly what we're watching for. And that's something that was vetted through the neurology team. And it's exciting. It's in the very first stages of monitoring, but we hope to be able to use it to monitor patients once we've proven that we can catch those events, and we have. So we are proving it's working.
Yes. And that just kind of goes back to the earlier bite that I did of communication, how important communication is, especially in this type of patient population.
Yeah.
Wow. That's great. And I love the fact that the neurology team was all on board for this too. And what a benefit for the family that actually can get some sleep. I bet you that is definitely a family, most likely, and patient satisfier.
Yeah. 100%.
Do you do scripting for the patient's family too then, obviously, so that they know, like, when you hear the stat alarm, you need to push this button? I mean, I'm sure there's education that takes place on maybe the EMU unit.
Yeah, the nurses on the unit will explain what the camera is to the patient's family. And we do have staff that will talk about that role in a little while that does help with that education as well.
Oh, good. That's great to hear. But I know that when you finally got those 3 devices, the world changed, and you had to pivot a little bit with the telesitter program, thanks to COVID. Tell us a little bit of your hospital's need during the COVID surge, because I happened to have been there in 2020, but it was January. And then shortly thereafter, boom.
Yeah.
So give us a little information on that.
So once COVID started, we immediately started asking if there could be any regulatory change for watching suicidal patients in the inpatient areas, because we had only been watching patients in the emergency department by telesitter, but it was always an in-person observation on the inpatient departments. Then, you've got COVID units, and you've got patients that are fall risk or at risk for suicide. And we didn't want to require somebody to be in the room with them for 12 hours, 8 hours, whatever it was. Even 4 hours is challenging without switching them out. But staff isn't always available to switch out. So we did get permission to observe, and some of the COVID rooms, so the doors have to be closed because of the pressure that's needed. But some of the rooms don't have windows, and then some of the rooms that have windows, the windows are frosted. So that was not allowing people to be outside the room but observing. So we got permission to put the cameras in the room, as long as there was somebody sitting right outside of the room that was ready to pop in if intervention was needed. So, communication would happen if there was any kind of concern, and then there's always the stat alarm. and then somebody would be sitting with their gown on, and usually it'd be like an N95 with they'd be wearing their regular mask, and N95 could be pulled right up and face shield pulled right down so they could pop in for any interview. More comfortable than sitting in full gear in a room.
Oh, absolutely.
Yeah.
But where did you get those devices? Those mobile devices, right? Because you only had 3.
Yeah, we borrowed them because the EMU, the need was less on R6, which is the floor that had the devices planned for the EMU in the future, but were being used for fall risk and other types of patients. So those were now more available, and they were kind and let us use them for the other scenarios.
Yeah, that was a perfect timing, wasn't it? I mean,
it was. It kind of
devices.
Yeah, it just kind of worked out. But so in addition, it also helped. So there was the suicide observation, but and then it just started to get floors. Because we hadn't done any education, because we hadn't expanded to the inpatient departments yet purposefully. And so then I think that gave exposure to certain units about how helpful a camera can be. And then people started to feel more comfortable using it for things like fall risk and, picking at dressings or IVs and things like that.
I think that, like I said, it was perfect timing to this to happen. But you did have to change some things, didn't you? I believe. Now that I'm sorry, I just started thinking about this. Did the policy have to change a little bit for inpatient? For monitoring for suicide, right? Did that change a little bit too?
We updated the policy, but I don't think it had to change too much.
Okay.
I think we did. I think we did say at one point, and I could be wrong because now stuff starts to blend together. But I do think that we said that no moderate risk. There was no on the inpatient units. We did not have levels of someone at risk for suicide. Whereas in the emergency department, you'd have your low, moderate, and high risk. Obviously, low risk wouldn't require any observation. Then there was moderate, and then there was high. Whereas in the inpatient departments, it was just all one thing. No matter what, you had to have an in-person. So what we had determined was that moderate risks could be watched by camera with somebody outside of the room, but a high-risk person that wouldn't qualify.
Okay.
So I think that was the only change, is really identifying the difference between moderate versus high in the inpatient departments where we hadn't done that prior.
Was that hard to educate to that, or were the nurses pretty adaptable to it and didn't have a problem with that?
I think we just had to do a lot of in the moment, talking, and supervisors had to help us, the nursing supervisors that were there off shift more frequently.
I think that was probably felt by many hospitals at that time, a lot of in the moment changes.
Yeah.
Any other process changes for the telehealth unit to the acute area? Because thinking about how do they get a device, right? Where is it located? Did you guys have to do all that?
Yeah, we did. I mean, like I said, policy didn't change too much, maybe just a little tweak here and there. But processes definitely are a lot different, since in the emergency department we only had ceiling mounted units, and now we have all these mobile units, which, as you said, are phase 3, where we got our additional 8 mobile units, which have been a lifesaver for us, for sure. We had to implement, or didn't have to implement, we implemented, I created resource binders for every unit. So with all the information that the units would need, that way, if a nurse came in and had never seen the telesitter before, there was a binder for them to go to and look through it if, they were confused or had questions, troubleshooting and whatnot. So we brought those out to the units, did a lot of education. I would come in on different shifts and do a lot of that education myself at first. And we implemented a new role called the gatekeeper. The gatekeeper is somebody who comes around and they're the keeper of the cameras. They store the cameras. They're really there as a resource for both the nursing units and the telesitters. They give all the breaks for the telesitters and, help them out when they need to. And they also can go around to units, set up the cameras, help do education in the moment for people that have never seen the telesitters before. They can help, with tech support if that's needed. They call AvaSure when they need to. They talk with our tech team when they need to ensure that the telesitters are actually just monitoring. So they actually do all of the admissions for the telesitters as well. So they don't ever have to take their eyes off the screen to type in admissions or anything like that.
Yeah, that sounds like the lead. We call them leads or whatever, but I like the gatekeeper. But you also have it set up a little. Well, you have it set up a little different though. The gatekeeper role, which I think is amazing, right? Because maybe I think right now they're still in the same room, right? Or have you moved them out of? They're going to be in their own area.
They're going to have their own space eventually. Yeah, they'll have their own office where they'll store the cameras, and there will be a workstation for them to work at and a secondary workstation in case we're actually moving our camera room off site. So we will have a second monitoring station in the gatekeeper office so that if we need to pull staff out of, like if we call out or someone needs to go home sick from our hub site, I guess we would call it, then we can pull someone off the floor or from a companion assignment to go and sit in the gatekeeper's room with them to monitor patients.
So I just want to explain this because I had the opportunity to talk to you about this, and we've jumped to we've jumped through some questions. So I'm going to circle back to the other questions, but moving to an offsite area, which I think you're going to have your hub area, but you're going to have actually at Maine Medical, you're going to have a room for the gatekeeper with a monitor. So truly, they're able to still give breaks to the monitor staff, even though they're not even in the same location.
Correct.
That is awesome. And yeah, because your hospital, Maine, what, 500? Am I off on my beds?
It's been getting close to 700 patients.
Oh goodness. So 700. It's nice to have that gatekeeper there to take these devices all over, because I can't imagine if I was a nurse way over here, and I've been to that hospital and there's a lot of walking around. So, it's nice to be able to have someone bring it to them. So you're still keeping that valuable resource at Maine, but yet you're still using that valuable resource for your monitor staff when they're off site. I think that's just a genius idea. And I know I've said that before, but I definitely wanted people to hear it because it really is.
Well, we are geniuses.
I know that, Val. Why do you think I have you on? Oh my goodness, this is great. So your program again. So the monitoring staff, is there any training differently? So with having your monitoring patients in these different areas, ED, inpatient, EMU, what is the training that you do for your monitor staff?
So our training really is just that we use some of the eLearn modules that AvaSure has given us, which is super helpful. So they start off there so that we can ensure that they can use a computer and that's comfortable for them. And then they spend a lot of time sitting, watching our current monitor staff, seeing what they're doing, kind of shadowing with them. And then partway through their orientation, they're having to switch roles. And then the monitor staff is watching them and ensuring that they are getting the process. And for the most part, well, not the most part anymore. We started out only using CNAs in this program, but eventually we realized that we would like to have more CNAs out on the floor. So we opened it up, and now we use what we refer to as hands-off companions, who were people who sit in with patients, and they know patients and they know about different medical equipment because they've been in patients' rooms. but now we allow them to go into the camera room with, it usually is a little bit more training for them, and, you know, making sure that they're empowered to ask questions. And thankfully with the gatekeeper role, I think that's been super helpful for when people are new in there, that even on the shifts that they're really starting out and being by themselves, the gatekeeper can be there to bounce questions off of and, ask for help when needed. But our
gatekeeper
training is
also
very different from area to area. We do a large general training.
They learn it all.
Yeah.
But I think with the gatekeeper, like you said earlier, they are taking that admission report, which again they're used to they know how to ask those questions.
Yeah.
So allowing the monitor staff just to keep, again, that eyes on the patient. So a lot of those questions can be fielded by someone that is a gatekeeper who has the experience. So I think that's really a value right there. And it's smart to expand because we're running, it's staffing and shortages are real. And so the way, if you can make this work and make it work safely, what you have, this is awesome. Now, about your resource pool, what does that look like for your telesitter programs? I'm pretty sure, if I remember, you guys kind of control both, right? The resource and the companions. But what happens like for your telesitter program if somebody calls in, or if maybe, basically if somebody calls in for the telesitter, are all the companions able to?
Not everybody. So most of our CNA companions are trained for it, but not everyone likes it.
No, it's true.
And we do 12-hour shifts. So, once they're in there, they're kind of in there for the day. But there are a lot of CNAs that are cross-trained to do it. There are a lot of companions that are cross-trained to do it as well. But we are now probably 50-50 with CNAs and hands-off companions that work full-time in the telesitter room.
So does it affect the resource pool at all, or no? Because they're kind of separate.
Well, I think it does, because we make the schedule and try to balance it, and then you pull people out and assign them to the camera room to be telesitters and gatekeepers. So if somebody calls out in the telesitter program, we will be pulling somebody that would have been otherwise assigned to a unit as a CNA or to a patient in person. So they're combined. So I would say it's impactful. Yeah.
Oh, absolutely.
Yeah. It's not a separate cost center. Like, we don't have separate staff, even though not everybody's trained, and we have people that are mostly designated to that one area. It's all in the same department.
Okay. All right. And then as you continue to use your telesitter program, how are you getting buy-in from leadership and your peers?
Well, I think that from leadership, most leadership, as far as, I guess I shouldn't say most leadership, because we did have some people that were hesitant. And what I mean is nurse managers and directors from some of the inpatient units were hesitant to start utilizing cameras for some of their patients. But I do think senior leadership was always on board, partially because I think some of them have visited other areas and have connections in other areas where telesitter programs were very successful. But again, where we do our check-ins through operational excellence, they get to hear a lot of stories and see statistics from the different KPIs that are done. Hannah she's basically the lead. She's our ops leader. And then we have had to submit demonstration of cost savings when we put requests in for capital budget, because we know it's a good idea. You have to prove to others that it's a good idea. So that's when you submit all your cost savings and that type of information. So I think you get buy-in there. And then honestly, people probably get tired of hearing we don't have enough companions, we don't have enough companions. And then when you can see that it's improved through the telesitter program, like our statistics went, I don't know, I'm just going to take a number. Like it went from filling, let's say 60% of the requests to filling 80% of the requests or something like that. It was a significant jump. So
I think it was 40 to 80.
40 to 80.
Very close to that.
Yeah. So it was a big improvement. So I think that's sharing that information is also how you get buy-in.
Yeah.
And all of the leaders, including physicians, it depends on what department you're in, but they get the risk reports too. So if they can see that a telesitter helped a situation, I think that creates buy-in.
Oh, absolutely. Absolutely.
Yeah.
I know we're getting close to question time, but I want to ask two more things. I know we talked a little bit about Hub, but you have such a successful program. So future plans for expansion?
Yeah. So we have future plans. So we don't have a lot of space at Maine Medical Center because we're on a peninsula and there's only so much you can grow. So we're planning on moving our telesitter program to a place called Hutchins Drive, which is still in Portland, but not right where we are located. Our hospital is located, and that will allow us to grow even within Maine Medical Center. And then it will, it's soon to hopefully become a hub for spokes of at least 5 Maine health hospitals, which will roll out, I think, one at a time. That's how we're imagining it. And then hopefully it would grow to all the Maine health hospitals.
Wow, that's exciting. That really is. I'm so happy to see that too. I am. You guys have such a great program. So I'm glad the sister hospitals are seeing the same thing.
Yeah.
And then final thing before I get to the questions is we always like to know about good catches. Any particular one stand out that you want to share?
I mean, there are so many ones, but maybe Val and I were actually talking about this right before, and we reminisced on a time. It was Valentine's Day, actually, because a patient got a Valentine's Day bundle, and in it was a package of Skittles, and the telesitter noticed that one of the Skittles didn't quite look like a Skittle, and they were able to zoom in, and it ended up being illicit drugs from an actual Skittles package. And so although the patient was able to get said illicit drugs, we were able to tell the nurse what we observed. So they weren't just like, oh my gosh, what happened to this patient? Yeah. We knew exactly what had happened. They had taken something they shouldn't have had. And, it ended up making it so that we could say, sorry, you can't have stuff brought in from outside.
Yeah.
And kind of just made that situation a little bit easier to handle. And another that was involving a patient who was on an air mattress and moved around a lot. And it was brought to our attention by an RL, as Val mentioned, those risk reports that we do internally.
Yes.
And the risk team was just so impressed with telesitter because, and I think not just this one time, but this time sticks out, that the patient was starting to slide. They set off the stat alarm. The nurses were able to get into the room. The bed alarm didn't go off right away. We set off the stat alarm first. So they were able to lower that patient to the ground, avoiding injury for the patient and, avoiding a full fall, possibly a fall with injury. And, but like Val said, there are a lot that come through risk reports that just make it obvious that the telesitters are doing exactly what they need to be doing. Mm-hmm. Those two kind of stick out in my head.
Those are great ones. And I know you have many. I do. So let's get to a couple of questions. The first is the emergency department can be very busy and fast paced. How did you overcome the issue of staff saying they are too busy and don't have time to put a patient on device?
Well, we don't, the devices are in the emergency department, the devices are in the ceiling. Mm-hmm. So they didn't have to go get it or bring it into the room or anything like that. the telesitters just got to turn it on. And they do have to give a report, but it makes more sense to do that rather than take one of their staff to be pulled to sit with a patient that's being observed for suicide, or constantly running in the room to check on somebody that might be a fall risk or some other thing. So I think it's kind of like a buy-in without even really having to explain.
Yeah.
Does that make sense?
Yeah, it does. And that was the next question, was what is the process for admitting a patient to the device in the ED? So obviously it's in the room, but they have to call or fax.
They fax.
Yeah.
Well, so they have to, I said that too quickly. Both. They call to have them turn the camera on, and then they fax over a report. And I think when we first started, it would sometimes take a while to get report, and they'd be like, oh, it's been hours, we didn't get a report. And the ED has just gotten more used to it. So it's usually like phone call and the fax machine's going off moments later. We also did a KPI about that. And so I think that, gave wind to leadership and just got everyone going in the right direction. But it was new. And
yeah, it's process change. It takes time. But of course you did a KPI. I know you. So what data did you use to justify expansion, and how do you track the data?
Well, we I don't know about tracking the data. We what did you say? Yeah, there's Orna. Yeah, Orna. But to justify expansion, I think that it was mostly cost savings, which we did via our little calculator and our Orna calculator. I don't know what the special little calculator that we have is to do our staff cost.
Our Wendy calculator.
Wendy calculator, yeah. I think that was probably the biggest thing, but then has monitored and collected and shared our data that we have from Orna. And we also did a survey.
Oh, so for satisfaction?
Yeah, do you want to talk about the survey, Hannah?
Yeah, we did a survey about satisfaction and communication, and overall, people, the satisfaction is great. The communication wasn't amazing, but we are doing a KPI on that now and making it better. But it was nice. We got 150 responses. And in the midst of a pandemic, to get 150 nurses to respond to a survey from not their department is pretty great. So we were
absolutely. I didn't even know that. That's awesome.
Yeah.
And I use the raw data a lot.
The calculator I think I've given you, right? Yeah.
The Wendy calculator.
Yeah, anybody. It's really not mine. Jill might have done it, so we'll give Jill credit. Jill Kaminsky. But yes, it's something that we can help with. Absolutely. I know we're getting short on time, but how about, have you used the devices for suspected abuse, either abuse of substance or maybe abuse by family members? Oh, I hate that subject, but it's so true. It happens. We know it.
I don't think specifically for that, but I know that twice recently we've gotten risk reports about staff being accused of abuse, and they were on telesitter, and the telesitters were able to say there was no abuse taking place.
Oh, okay. So the opposite then, really.
Yeah.
It saves a lot of time. So the regulatory requirement is that any time a patient says anything about that might involve the words or anything similar to abuse, neglect, or exploitation, it has to be, reported to DHHS, and then it gets put in as a risk report, and then it has to be reviewed, and you have to interview people. It all has to be taken very seriously. And so having somebody that was a witness to it makes it so much easier.
Absolutely. Well, I know we're out of time. We have a few more questions, but find out who they're from and if I can get them in touch with you. Really want to thank you so much. It was so great to have you be able to present your amazing program at Maine Medical to all of our customers and prospects here at AvaSure. Again, very much thank you.
Thanks for having us.
You are
Thank
welcome.
you.
And for everyone else, we have a little break, and at 3 p.m., the closing session is next. And it is something that's near and dear to my heart. It's workplace violence, and you don't want to miss it. So I look forward to seeing everyone soon. Okay, bye.